Is my screen showing? Is it showing?
Yes, sir, it's visible.
Okay.
Perfect. You can start. Yeah.
Just a sec. So I will try to be as brief as possible. So die hard in double trouble means that we have both iridodialysis and zonionodialysis. We will deal with them separately, and then again, and I'll try to show you my way of doing it, which I've just found out. So to begin with, we have a galaxy of speakers, Dr. Ayonmont and Dr. Arubhomik from Disha, Kolkata. We have Kumar J. Doctor Sir from all the way from Andheri, West Mumbai, from Dr. I Institute, Dr. Meena Chakraborty from Chakraborty Eye Institute, Trivandrum, who manages the posterior segment out there, and Dr. Boris Maligan from Foydrov Eye and Eye Microsurgery Complex, all the way from Moscow. He may not be, he's on the move. He may have sent me his presentation. So if he cannot join in, I will play his presentation. So going directly to ciliary sulcus, which is the point of interest where of all sulcus fixated lenses. What is ciliary sulcus? Is the potent space in between the iris, posterior surface of iris, and the anterior surface of ciliary body and the lens. So this is the lens sitting in the ciliary sulcus. This is the ciliary sulcus proper just in front of the capsule. So this is what we intend, ab interno, entering through the ciliary. Let me take the pointer. Entering ab interno and coming out through the surgical limbus. So this is what we intend. This is the pathway from the sclera to into the ciliary sulcus, but it is not so easy because this is a blind procedure. Let us first understand the limbus. This is the cornea. This is the sclera. In between, we have the limbus, anatomic limbus at the conjunctiva, surgical limbus. And now we have is between divided into white zone, blue zone, and then white zone. In between, we have the mid-limbal line at the decimus membrane, end of the Swallows line. And end of the white zone signifies the end of the surgical limbus. So what is the dilemma here? This is a blind procedure. We cannot see the ciliary sulcus through the microscope. So we need an indicator on the scleral surface to make us feel secure that it has gone into the ciliary sulcus. So we need an important landmark. So the location, this is the iris, this is the ciliary sulcus. Ciliary sulcus is 1.5 millimeter deep from the sclera perpendicularly. And if you go parallel to the surface of iris, posterior surface of iris, it will go for about 2.5 millimeter and hit the sclera about 2 millimeter behind the posterior surgical limbus. Therefore, posterior surgical limbus is an important landmark. Then we have the pars plicata and plana. That will be this. If you use a carved needle, just a sec. So this is a straight needle track should be directed parallel to the posterior surface of the iris, 2 millimeter behind the surgical limbus. If it's a carved needle, it becomes a little bit more difficult. This is 2 millimeter behind the surgical limbus. It has come out the magnified view. This is a nice diagram, pars plicata, plana, ciliary sulcus, and in front you have iris. So I would ask Dr. Meena Chakraborty to take over the presentation. I stop sharing my screen right now. Yes, it's fine. It's coming.
Please, is my screen visible to everyone?
Yes, it's
yes, it is perfectly visible, and you are perfectly audible also.
Absolutely nice.
Thank you, Dr. Debashish, for having me in on this course, and good evening, everyone. I'll be speaking on anterior vitrectomy for cataract surgeons. I know we are running short of time, so I'll try to limit my presentation to what is absolutely necessary. Dr. Debashish, please feel free to stop me whenever you feel that I'm exceeding the time. So the best way to prevent vitreous loss is to prevent a posterior capsular rent from occurring and a vitreous loss from occurring. So you should be aware of the signs of an early signs of a posterior capsular rent, such as a pupillary snap, a sudden loss in depth of the anterior chamber, poor followability of your nuclear fragment, or a small spidering of the posterior capsule. And once you know that warning signs are there, you should do everything to prevent the occurrence of a posterior capsular rent. Once there is a vitreous loss, do not fail to identify the vitreous. Perform preservative-free triamcinolone acetonide particulate staining after OVD removal. And again, once you have completed the anterior vitrectomy, put in more TA and see to it that there is no vitreous strand. Here, this is Dr. Rupp's video. He has found out that there is a small strand of vitreous here right at the section. He's sweeping the spatula to find out if it is there. He stains again, brings it to the pupillary area, and then it is cut and aspirated. So you make sure that you don't leave behind any vitreous in the anterior chamber. Do not use the phaco incision for vitrectomy. Use the paracentesis or a separate incision for a bimanual anterior vitrectomy. Here is a surgeon using the main incision. This should not be done, and there is also too much TA staining the vitreous. So these are the most frequently asked queries with respect to vitrectomy, the type of vitrectomy that you should do, whether it's a bimanual anterior limbal vitrectomy or to the pars plana approach, the gauge to use, the parameters, the sequence of cut rate, aspiration, bottle height, the direction of your cutting port, whether it's face up or face down, where to start the vitrectomy, how much vitreous to cut, the ideal OVD to use, and whether the anesthesia should be augmented. As I go through my talk, I'll try to cover everything briefly, highlighting the pertinent points. In most of our theaters, like how there is a emergency code, we also have a code V in a theater, which indicates to the scrub nurse as well as the circulating nurse that there has been a posterior capsular rent, and they should keep everything ready for the surgeon. As a posterior segment surgeon, listening to my patients, I know exactly, the patient knows exactly when the posterior capsular rent has occurred or when the nucleus drop has occurred. They tell you that, sir, madam, suddenly there was some commotion in the theater and the surgeon made a sound. So instead of doing this, you should have the emergency vitrectomy kit ready, and there should be a secret code between you and your scrub. There are different types of anterior vitrectomy. You can do a dry vitrectomy when you have a small amount of vitreous prolapsing into the anterior chamber, the bimanual automated limbal anterior vitrectomy, or the pars plana approach. Let us look at the settings for anterior vitrectomy. Use the maximum possible cutting rate that is available, the lowest vacuum. The cutter should be advanced or held stationary, and never pull back the cutter while you're cutting. Do not use low speed, high suction, and cut while pulling away. If you do not have a dual linear mode in your machine, this is the setting for the machine: irrigation, vitrectomy, followed by aspiration for anterior vitrectomy. And if you're removing the cortex at the end of the vitrectomy, it is irrigation, aspiration, and vitrectomy. Do not fail to understand the vitrectomy settings, and the bottle height must be balanced in such a way that you have just enough fluid flowing into the eye to keep the globe formed for you to work around the vitreous. These are the settings that I use, the same settings that I use for my posterior segment cases, the highest possible cut that is available on the machine. This is the Guida S3 VIP machine, and the lowest vacuum. This is a slide all of us are familiar with. The higher the cut rate, the less is the traction at the base, the vitreous base. So this is a patient who had undergone a scleral fixated IOL. On the table, everything was fine. And 1 week into the postoperative period, we noticed that there was vitreous in the anterior chamber. The vitreous is stained with triamcinolone acetonide, and the triamcinolone acetonide that is free is being blown out of the eye. You can see that there is vitreous right at the center. A bimanual anterior vitrectomy is performed. After compartmentalizing the vitreous, injecting a dispersive OVD into the anterior chamber, the vitreous is completely cut and aspirated. The cutting port facing upwards, because definitely the surgeon would like to see what he is cutting. And at the end of the procedure, again, a little more TA is put into the eye to see whether the vitrectomy is complete or not, and that completes the case. So there are certain misconceptions regarding limbal anterior vitrectomy, and this is why the limbal anterior vitrectomy fell into disrepute, and people started looking at the pars plana approach for anterior vitrectomy. It may cause aggravation of the posterior capsular rent and aggravate the vitreous lock. This is because the surgeon does the arachnic blunder of placing the cutting port too anteriorly, so that he'll be dragging more and more vitreous from the vitreous cavity to the front of the eye, or he uses a coaxial vitrectomy where there is infusion as well as cutting in the same port. And when all this fluid goes into the vitreous cavity, it will hydrate the vitreous and produce more vitreous to prolapse into the anterior chamber. Or if he is trying to do a vitrectomy like I showed you previously through the main wound. There is poor access to the subincisional vitreous, which is a wrong statement because you have the ability to change your ports from one side to the other, and you can actually reach the subincisional vitreous. Potential trauma to the iris and anterior capsule may occur if you're not very careful, and it has a necessity to remove more vitreous than that is necessary, which is not the truth. If you're cutting the vitreous, you start cutting by putting the port just below the posterior capsular end in the anterior vitreous with the cutting port facing upwards, so that all the vitreous that is there in the anterior chamber is dragged back into its home. There are two exceptions where a pars plana vitrectomy is necessary. For example, like in this IC where we are dealing with zonular dialysis, where there is a knuckle of vitreous prolapsing, it would be better to cut it from the posterior segment, and vitreous is noticed after IOL implantation, in which situation also a pars plana anterior vitrectomy is necessary. So I'll come to the last part of my presentation is, should an anterior segment surgeon perform pars plana vitrectomy? There is a definite learning curve. You need mentoring, a wet lab experience, and also should be proficient in posterior segment techniques such as intraoperative indirect ophthalmoscopy, and should also know how to treat a peripheral retinal tear. The risks of retinal tear, retinal detachment, etc. is not very high. If you're going to use a trocar cannula system, beware that you require a very firm globe to introduce a trocar cannula system. And if the globe is not fully formed, you might get the pressure that you exert while inserting the trocar cannula system can cause the iris to prolapse and more vitreous to come out through the section. So the ideal way is to do a straight stab-in incision using the MVR knife. Do not attempt a pars plana anterior vitrectomy for the first time in a complicated case with an open globe and when the surgeon is under duress. There are certain advantages of a pars plana anterior vitrectomy where you bring home the vitreous back to its home. There's a definite endpoint for the vitrectomy. It limits the amount of vitrectomy that is necessary. And there is also better access to the cortex. So your infusion can be either limbal or pars plana. I would prefer a limbal infusion if you are going to do only a minimal anterior core vitrectomy. But in this situation, I'm using a pars plana infusion because I have to do a full-fledged vitrectomy. There's a drop nuclear matter in this patient. The sclerotomy that you give, that would prefer a straight in stab sclerotomy, which you can suture at the end of the procedure. Do not go for the trocar cannula system in a freshly opened eye because you have to exert a lot of pressure. This is a patient who has had a vitreous loss at the time of surgery with dropped nucleus. And you can find out, you can see the amount of force that has to be exerted to put the trocar cannula system. There's a new trocar that is open for the case, but even then so much pressure is necessary. And after completing the cutting port faces upwards, take care to preserve the capsula, what is remaining of the capsular bag, because you'll have to implant an IOL into the ciliary sulcus and continue with the vitrectomy. This is the end of the case. After putting in the IOL, the vitrectomy continues. So do not purposely violate the anterior or the posterior capsule. This is another such patient who had a dropped IOL. And you can see that we are using the remnants of the capsular bag for implanting positioning the IOL back into the ciliary sulcus. So during an anterior vitrectomy, limbal anterior vitrectomy or the pars plana vitrectomy, take care to preserve the capsular bag. Do not fail to provide aggressive antibiotic prophylaxis. A ruptured capsule increases the incidence of endophthalmitis. So these are the frequent queries which are answered. I hope I have covered what is necessary. I thank you very much for your patient hearing.
Very much, Dr. Meena. It was an exhaustive and excellent lecture.
Excellent talk, ma'am.
Excellent and
Excellent.
comprehensive. It couldn't be more comprehensive. And I feel like doing fellowship under you once more. Anyway, Dr. Arup Bhomik, it's up to you.
So, how to manage my topic. Thank you, Devashish, for including me in this. I see my topic is how to manage stationary, mainly traumatic subluxation. I have no financial interest to disclose. The traumatic subluxation is generally localized loss of January. It may be generalized, but maybe most of the time it is a localized. The strategies is as dictum shows in the literature and different peer-reviewed journal. There's the 3 clock hours is more than less than 3 clock hours. Then probably the nucleus is more stable. It is only implanting CTR is enough for this case. And if it is more than 90-degree, capsular fixation is with the sclera is important. Even in the traumatic cataract, when it is a very stationary, even you can manage the case with implanting CTR only, but it is stabilize the black is important to center the lens. It is very important. Otherwise, the lens IOL back complex may be slightly decenter. But it is actually depends on the operating surgeon, is a ultimate judge in this case, and the surgeon should be flexible and be prepared to handle a greater degree of difficulty during the operation. This is the key to success in the subluxation case. If you have to be prepared to handle the greater degree of difficulty. In the meantime, if you think you don't have a CTR ring or armate segment, it is very difficult to manage in some cases. So the factors which can complicate challenge the cases, complicate the case further: hard cataract, shallow AC, vitreous in AC, hypermature cataract, etc. So these are the cases, type of cases with the subluxation is much more difficult to handle. So surgery is to stabilize the capsular bag and IOL the capsular bag. Sometimes it is not important to put the IOL in the capsular bag. It is even important to put the IOL in the sulcus and capture the capsular bag. This also very good technique, and I will, if time permits, I'll show you. So it is most important to stabilize the capsular bag either to CTR or the capsular bag complex through suturing with the sclera, or you can stabilize the capsular bag with IOL itself. So these are the imatorium, iris hook, CTR segment, Cionni ring, Cionni ring, single or double arm, capsule anchor, which is actually used for the post surgery decentration case. And I use a lot of, I think OVD is an important factor for this type of case. Definitely OVD is the most important factor, and I use my pump in subluxated case. These are the cases. This is the anchor, which actually used for the post surgery decentration. Generally, the surgeon does not prefer it the primary cases, primary surgery. And this is the iris hook, capsular hook, and that is this is a nice capsular hook by I think suture is material which can we fix with the complex with the 10-0 which actually now obsolete because long-term degradation of this suture is very common. Prolene is ideal, and the Gore-Tex sutures, which is off-label use, actually not available in our country. And some after Yami showed us how to use 50 Prolene to fix the CTR Cionni segment or armate segment. These are the stage we have to important every stage: incision, rexis, hook, slow motion phaco, CTR, and IL plantation and CTR. You have to be performed perfectly in all 6 stages to get a good result. And these are the case CTR. You can implant CTR as the beginning of the surgery if your subluxation is less. Even some surgeon is preferred to put the CTR in the beginning of the surgery because CTR stabilize the capsular bag very well. Then it is very easy to perform phaco emulsification. Remember, sometimes CTR can increase the area of subluxation. So if you plan to do a CTR before doing phacoemulsification, you better put to capsular hook and CTR. And this is probably the ideal stage of the CTR. If you able to do so much, go without giving the CTR, you can little bit of cortex and the fragment is there. Now it is very easy to implant CTR into the bag. So it required less force. Even, but is very important to CTR. Timing the CTR is very important. This is a grossly subluxated lens. I stabilize with the capsular bag with the Cionni segment and part of the Cionni segment. And for hook, you can see I am hooking the Cionni segment which to stabilize the half of the bag with the capsular hook. And even with I am maintaining, you see that my FECO parameter, even with this small low parameter, there is a catch of the posterior capsule. So the timing of CTR as late as you can, but as soon as you must. This is the key for CTR. So as I time, there is a time constant. I am just discussing one case only. This is a case I try to do a Hoffman pocket. It is a beautiful technique by Richard Hoffman, how to show this knot under the scleral flap, the reverse scleral flap. It is starting from the clear cornea, but you can jolly well make a remove the conjunctival peritomy. You can do a flap. You can do the same thing under the corneal flap. Now there is no problem to do a make a flap. Even when I do the Hoffman pocket, I always try to mark how far my tunnel goes. There's very important stage. Just mark, and you made your life easy, because when you pass the suture, it is very useful. And sometimes I also make a stent of the tunnel. This rhexis is an important factor for the any kind of subluxation, because you have to have a 2 millimeter area zone to put a CTR or Cionni segment or CTR segment, Cionni ring, to stabilize the bag. Otherwise, if you don't have the 2 millimeter edge from the equator, that Cionni segment or arm segment can slip out of the bag. Even CTR can come out from slip out of the bag and come into the anterior chamber. So it is very important to keep a 2 millimeter zone. And it is very important to do the rhexis. In some cases, you need to apply the counter force to complete the rhexis. So now I'm just the FECO part. I'm just this is a single 90 Prolene, because unfortunately you don't have the double 90 Prolene. You have a single 90 Prolene. So I pass the remove the all the hook from this and keep the hook in the over the iris and keep the space, so that I cannot there should not be an injury in the capsular bag with the needle. Just I am passing the suture with the whole of this needle, and again I am reverse technique. I'll out of the I am passing the suture out of that scleral pocket. Yes, and you easily come out from the scleral part. I think it is quite visible. Now I am to loop, and now I am putting CTR. I am putting CTR. Now I'm putting CTR, putting Cionni segment. Now just bring the loop out of from the scleral pocket, and now I implanting IOL. I am not tightening the suture now. I implanting the IOL, and now I tightening the suture so that I can center the IOL perfectly. Because if you tighten the suture fast before implanting IOL, you can there is slight decentration of IOL. So I am implanting IOL, and after that I suture. This is a technique I love to do. I just this is a traumatic cataract, and I do the phacoemulsification, keep the bag there here. This is a reverse technique. I am not fixing the bag with any kind of segment or Cionni segment. I'm passing the needle, which is actually to bring the lens haptic actually, and keeping the bag there. Over that I doing the glued IOL and capturing the optics, capturing the rhexis with the lens. So in that case, I actually preserve the bag and fixing the IOL solidly. There will be no phacodonesis, and keeping the bag in very advanced cases. I am doing this. And thank you so much for, I think I finished my talk.
Just
My
finished
time is
on
up.
time.
Thank you.
Thank you. Now, Dr. Kumar, it's all up to you. Arubda, thank you for your beautiful presentation.
Okay,
I wish could
I
go
have
on and on.
I have another presentation. Sorry, I am leaving this course.
Okay, thank you so much.
First of all, I'd like to thank Dr. Devashish to have given this chance to me, and he calls it double trouble. So you have iridodialysis and a zonular dialysis. So I'll show two videos. I know the paucity of time. This was a traumatic subluxation and a bit of the iris that was lost, and there was vitreous coming out. So I go ahead, put Kenacort and do the staining. I do a little bit of angiovitrectomy. This is a trick that I like to use before we put the endocapsular ring. So I like to put the viscoelastic below the anterior capsule till the equator of the lens, and that pushes the cortex down. Once that is done, I'm going ahead and doing this all around. Then I thought I will put capsular hooks, but I have now decided to put the endocapsular ring to give me additional support in the subluxated area, which you can see through the iridotomy which had happened during the injury. So this is a endocapsular ring going there in that area. Once that is done, I thought I'll need additional support with capsular hooks, but it was quite tricky. So to make a side port for capsular hooks is very different than that you make for iris hooks. So this is one support that I got. Once that was done, I went ahead and did phacoemulsification. And once the phacoemulsification, you can see that this lens is not all that hard. So I'm going to remove this cataract, and once that is done, we put a lens. And then I will show that how exactly the iridotomy which had happened, we will suture it or not. So this is the phacoemulsification that is happening. And once the phacoemulsification is completed, because the way we injected the viscoelastic below the anterior capsule, you will see that there is no entrampment of the cortex at all. So this is a bimanual IA. Since the endocapsular ring is supporting the area of the subluxation, the capsular hook is just holding on to the margin of the capsule, but that's okay. It really doesn't matter because the stretch on the capsular bag is quite good. So there is no fear as that part is concerned. So once I've done this, now we'll go ahead and put the IOL. And once you put the IOL, you'll see that how are we going to repair. Now I realized that the capsular hook had no play at all. And so we removed it. We go ahead and put the lens in the bag. Now, all the steps, you will need little micro forceps or fine forceps like a micro grasper so that you can hold the iris to do a fourth row pupilloplasty. So I didn't repair this. You will see at the end of the procedure that when we pull the iris with the micro grasper, there is a huge iridotomy which had happened at the time of the injury itself. So once the lens is in the bag, we go ahead and use the micro grasper. And once you can see that a little bit of pilocarpine, and now you can see the huge iridotomy. So part of the tissue of the iris is actually missing. So this is a micro grasper that I'm using. And now I use a technique invented by Amar called the fourth row pupilloplasty. So I decided that, instead of going through a 26 gauge needle, sometimes I find that it itself causes a bigger bore. I like to pass a 9-0 Prolene through the iris itself and then hold the iris on the opposite side and pass again the needle through that instead of putting a 26 gauge to the opposite side and then doing a railroad. So this is what I have found, that if we use a 26 gauge, the 9-0 Prolene is much smaller. So I like to hold the iris itself and then push the 9-0 Prolene across the iris instead of putting that to a 26 gauge. So this is one sweep that you can see. And once that is done, again, get the loop inside and then a 4 loops, that's a 4th row. And then just pull the 2 threads and it will bring the iris into good opposition. So you can see that once that is done, we go ahead and just pull the threads on either side. Once that is done, you can see that the pupil is becoming nice, small and round. And then you need micro scissors to be able to access that area. And the same thing will be done twice, say second, 4th row pupilloplasty, and you got a nice round pupil. So this can happen. There was an area of subluxation, which could be quite easily managed, and the lens was in the bag. I'll show you one more case. This is a very interesting history. The patient comes to me and says when he sits, he cannot see, but when he's lying down on the bed at night, he can see very well. So the question was why that really happened. So this is how the patient came to me. You can see an endocapsular ring with the lens and the whole back complex, which is subluxated. So this history was very interesting. So when I said, how can you see? Because when you will see when he lies down on the operation table, you will see that the whole bag is very well centered. And that's the reason why he could see very well. But on the slit lamp examination, this is a video on slit lamp examination, you can see that the whole back complex has gone down. Now the question is what to do about this back complex which has gone down, and now the patient is lying down. So yes, I did put a port to support me from a little bit of irrigation to give us support on the either side. So there are many ways of handling this. One is to remove this whole back complex and do a glued IOL, remove the whole back complex and do a iris crop posterior fixation. But I thought of something entirely different. So I decided to suture this same back complex back in its own position. So here you can see that I'm putting viscoelastic. I did a Hoffman's pocket, then do a railroad technique. From here, I'm passing a 26 gauge needle from below. The spot here that is very, very important is here I got the endocapsular ring and the haptic of a Technis 1 IOL. The same spot, remember friends, we have to take it on the opposite side. You can't do it, otherwise you'll have a cyclo-rotation. Of course, it's not a toric IOL, but remember I marked it. So you'll be able to see that. And this is a railroad technique. So one suture goes from below, and now I'll pass the same thing again. Again, the needle is going through, and another 26 gauge needle goes from above the endocapsular ring and the haptic. So this is above, just behind the iris, but above the endocapsular ring and the haptic. So this is like creating a loop, which is around the endocapsular ring and the haptic. So I've got this back into position, and the same thing we will do on the opposite side. So remember friends, as I said, 90 degrees across, the same spot of the optic haptic junction or where the endocapsular ring is what you have to capture. So here again, this is from below. I've got the endocapsular ring above and the haptic of the IOL above the needle thread that we have just passed as a railroad technique. And the other one will be above. So the one was below and this is above. So it's again creating a loop around the endocapsular ring and the haptic. Once I got this on both the sides, I will then tighten this. So I've actually sutured the endocapsular ring and the haptic back into its position without removing the whole thing. So this is quite possible now. So I've sutured on one side. So we really didn't need to do any explantation or anything here. And this we got and we very well centered IOL, sutured the conjunctiva, and this is how I've captured the same bag into position. Thank you for the paucity of time. Thank you very much again, Debashish. You have given this chance to me. I finished well before time. Hello? Yes.
Hello, Debashish.
He's not there, I think. Mohammed, you can take over. You are the boss.
Is there any other speaker apart from me? I think Debashish himself.
Yes.
Okay. So,
before you proceed, I just like to bring in this to information that at 5:25 we'll be like this halls will automatically be closed for the inauguration. Yes. So we can just take care of the timings, please.
Thank you, Dr. Kumar. That was excellent talk. I point very well taken. I just went a little bit offline. Thank you so much. And I will, as I don't think Dr. Maligan will be able to join. Dr. Anmonto, you want to continue?
you want to continue? So you do, and then I will be.
No. You go ahead. You go ahead. Yes, you are there.
So
just
coming to the very basics. Coming to the very basics. I mean, I'll be talking on the various suture materials and fixation devices to manage these cases. So thank you, Debashish, for giving me this opportunity. Though we must always remember that these sort of cases are extremely challenging, and we have to look at a long-term horizon so as to not the surgery. I mean, so the surgery stays for long. I mean, in at least a 15-20 years timeline. So coming to suture materials, they should have an excellent tensile strength, tissue biocompatibility. It should be a monofilament suture with a lifelong integrity. And these are the preferred suture materials. 9-polypropylene is the suture material of choice. 10-polypropylene has fallen into disrepute because of its high breakage chances. Gore-Tex suture is now another suture which is coming in the horizon, and it's not available in India. It has to be imported. And it has properties like adverse events related to suture are very rare, though some scleral necrosis are recently being reported. It has a high tensile strength. It has a very good visibility and minimal inflammatory response, and it's very easy to manipulate. The only disadvantage is its needle is not that sharp, so and its thickness is huge, so that it might not always be possible to bury it in the sclera. So sometimes this need to be brought out with the help of a 20 gauge, 25 gauge needle or forceps. So for as coming to suture needles, it should be round body needle when we are intending to suture an iris in place, because a cutting needle in that case will be injuring the iris more and causing a buttonhole, and which might give way. And in that case, the scleral passage has to be facilitated by a 25 gauge needle as a passer. So cutting needle is preferable for procedures involving the scleral fixation only. Another suture material is 60 Prolene, which we are currently using in order to fix iodolisis and capsular tension rings and segments in place with the help of diathermy. Coming to fixation devices, there are 3 types of rings and segments. One is the capsular tension ring, then comes the Cionni rings, and then the capsular tension segment. So this is a Citure. Always there are 2 diameters written on the box. One is the Citure in its uncompressed state, and the other diameter if the Citure is placed in the back, the final ultimate diameter is written on the box. Usually it's 2 millimeter less than the uncompressed diameter. So for inserting a capsular tension ring, this is how the general principle. The capsulotomy has to be complete and should not be more than 3 to 4 clock hours of zonular weakness. Preferably inserted using an injector. Trailing end of the Citure must end up in the capsular bag. Aiming it to the greatest area of zonular weakness might help avoid iatrogenic trauma to the zonules, and place the Citure, as Arup said, as late as possible, but as soon as necessary. Citures make capsular cortical removal more difficult. So these are some of the Citure injectors, and this is another Citure developed by Bonnie Henderson. It has scalloped edges to facilitate cortical cleaning up. Now here we are placing a Citure on the left-hand side photograph. So it will target the subluxated area first, followed by the rest of the area. And on the right, you can see a Citure is being put in the eye. Cionni ring has 3 models. It has a single, model 1L has a single fixation hook located at the trailing end of the ring. Model 2C has a single fixation hook located at the leading edge of the ring. And model 2L has 2 fixation hooks in 2 different locations where 2-point fixation is required. So a modified CTR, that is a Cionni ring, incorporates a fixation hook that courses anteriorly and centrally in a second plane. Over here, you can see there is a second plane. It is 0.25 millimeter above the plane of the tension ring. The fixation hook wraps around the capsular axis edge and rests on the residual anterior capsular rim. Over here, you can see the capsular rim, and this hook rests over the capsular rim, and the free end of the hook has an eyelet, through which a suture can be passed and used for scleral fixation. These are capsular tension segments. These are partial PMMA ring segment with 120-degree arc length and radius of curvature of about 5 millimeter. Like the modified CTR, it also possesses anteriorly positioned fixation eyelet. So here you can see a MS segment is being used and is dragged into its place. The MS CTS is a modified design of Cionni capsular tension ring covering approximately 1 quadrant. A single iris retractor hooked into the hole can support the segment during surgery, as Dr. Arup has shown. Following surgery, there can be removed or sutured in the sclera for permanent support. A CTR along with CTS can be used for cataract removal to give an additional circumferential support in case of advanced zonulisis. So these are iris hooks made of polypropylene. It stretches and stabilizes the iris during cataract surgery. It has an adjustable silicone stopper, which allows to adjust the pupil size. So these iris hooks are used in case of this particular traumatic iridodialysis patient, in which the iris will interfere if not put in the hooks, if not put in place. It will constantly come towards the tip of the phaco. So in order to avoid that, we need to put 2 iris hooks to retract it from the operative site. And as the surgery is over, then the suture is placed to cover up the iridodialysis defect. Capsule retractor stabilizes the capsular bag during cataract procedure. And this acts like artificial zonules. It provides stability. Where iris hooks would only pull the capsular axis margin, the retractors are designed to reach the equator of the bag. It has a loop or an olive tip at the distal end, which minimizes the risk of puncturing of the capsule by providing a broad area of contact. This is how the capsular hooks. On the left is the MST capsular hook with a broad loop and a Chang modified one. And on the right, you have the capsular hook manufactured by the Madhu Instruments. And this is how the hooks are used in place. So on the left, you can see a MST capsular hook being used. And on the right, the Madhu Instrument olive tipped capsular hook in place. So broad capsular hook has one particular problem, that the CTR might get entangled into the loop, like it happened in one of my cases, which it's my mistake, because I could have loosened the capsular hook before putting the CTR in, which I didn't do. And the CTR went right through the loop and the whole thing was a mess. And now coming to the biggest fixation device, that is the intraocular lens itself. Like the Amane or glue dial technique, we see the haptics of the IOL itself is acting as a fixation device to put the lens in place. Thank you so much. Thank you so much, Devashish, for giving me this opportunity. Over to you.
Thank you very much, Dr. Ayon. You were just in, you said 2 minutes. I'll just go in for the presentation straight away. This is Dr. Malogan's presentation.
Your video is
implantation of Suture.
His video is running.
I think your view option should be minimized. View options on top.
Suture is completely retracted inside the injection device.
Say it this way.
No, view options at the top. It should be minimized. I mean, it's more than 150%, I think.
You can play it still.
Devashish, I think you should move on to your presentation.
Will help to stabilize the
Okay.
back. You see how easily the
Is it visible?
sliding along the equator.
So it's
Yes.
blown off.
The trailing
I can see
It
it.
has gone bigger.
place the device.
Dr. Datta, you can start by resharing it, I think.
Okay, I'll do that. Stop share.
Devashish, I think you present your own presentation. I mean, that I think is more interesting.
Okay, that is the same video that Dr. I'll do that then. It'll be short. Is it gone? Stop share. Share.
We still have 10 minutes, not to worry.
I'll go straight to the video that is. No point.
No, but your screen should have to be minimized. I mean, it's hugely
Not
blown off.
visible?
It's huge.
Is it coming?
I mean,
Is it
you
coming?
go to the view options and minimize it.
I think it's yours, Monta, because I'm seeing it properly.
Yes, sir, I can see it properly too.
Yeah.
Then I'm playing. Please.
Please play.
Okay.
Yeah, people.
I had a blood
Interesting
trauma
video.
and developed 3 clock hours of dialysis and zonular dialysis and thereafter significant cataract.
Your case is a bit complicated and the literature also does not help much. But don't worry, I have a new idea to fix both the defects at one go. Let's discuss what we are going to do.
Okay, doctor, that's very nice of you.
Hoffman pocket is made adjoining the area of dialysis. The needle is passed across the pocket just in front of the ciliary body at the ciliary sulcus. Through the peripheral torn iris from outside inwards and brought out of the eye by railroad. It is passed through the eye of the segment CTR. The suture is guided out through the scleral pocket by passing through the peripheral iris from inside out. The segment CTR supports the subluxated capsular bag and the iris is approximated to its root by the suture, that is, hangback repair is done. All this by a single loop of suture, so you can kill both the defects at one go. Just removing your conjunctiva adjacent to the dialysis.
Basically, this removal of conjunctiva was not much required.
I'm making a Hoffman pocket here. First things first, triamcinolone is used to stain up the prolapsed vitreous. I stain your anterior capsule with trypan blue.
Oh, doc, I can't see any light. Is everything okay?
All is well, don't worry. And plug the prolapsed vitreous with cohesive viscoelastics. Now I remove your anterior capsule carefully. Two stab incisions are made adjoining to the area of dialysis. I have fixed the unsupported portion of the capsular bag temporarily with capsular hooks. 23 gauge trocar is placed on the pars plana.
Oops, doc, be careful.
Take it easy. Anterior vitrectomy is done through the pars plana with the cutting port facing the optic disc, lest it injures the still intact capsular bag. Irrigation is maintained in the anterior chamber. This keeps any more vitreous prolapse at bay. Hydrodissection and careful bimanual rotation of the nucleus is attempted. Vitreous is removed from anterior chamber also. Nucleus is divided by direct chop. I am removing the nucleus by phacoemulsification. Now that some nuclear mass has been removed and the bag seems unstable, I think it is high time to support the capsular bag by a CTR. CTR is carefully placed in the bag.
Is it all okay?
Oh yes, we are going fine. Now we are going to use the Cortex suture as you are pretty young. I told you that it is off-label.
That's okay, doctor.
We enter with the needle through sclera at the junction of 1/3 and 2/3 of the area of dialysis and pass through the outer edge of the torn iris and brought out of the eye through the pupil by railroad technique. The eye of the emerge segment is threaded by Cortex suture. Now we do a similar pass through, this time by a hollow 26 gauge needle. The needle is docked and brought out through the bed of the Hoffman pocket. The capsular segment is now placed in the bag. Oh no, the suture has passed over the iris.
Oh, doctor, what's the problem?
Don't worry, it will be all okay. I will be releasing the returning suture, and this time I will be doing it right. A 26 gauge needle is bent in a bow-like fashion, passed through the bed of Hoffman pocket, and then through the peripheral torn iris and brought out at the incision. The cut end of the Cortex suture, which has been eyed through the emerge segment, is threaded onto the lumen of the needle and punched with a needle holder so as to keep it in place as the needle is withdrawn out of the sclera. The segment is aligned inside the capsular bag. The combination of the emerge segment, CTR, capsular bag, and the iris is drawn to the periphery and fixed to the sclera by titrating the knot.
What about the IOL?
Oh yes, the multipiece IOL is placed in the bag. I use the multipiece as we can salvage the situation by doing a glued IOL if the need arises. The knot is buried inside the scleral pocket. Conjunctiva is apposed. You're doing fine. You can see 6'9" with 0.75 diopter cylinder.
Thanks, doctor.
To kill both the dialysis at one go.
That was an excellent video, Devashish.
Very nice, Devashish.
Thank you. Thank you.
The device designed for scleral fixation.
I think we have only 2 minutes.
Let me see as much as I can.
Dear colleagues, let me introduce you. Pilot of CTR is fixated.
Are there any questions? Because we need to sum it up in 2 minutes.
I think you can give us 2 minutes more. That will finish it up.
The device is easily sliding.
It's a request.
During surgery, CTR is injected in the direction of the zonular defect. In that case, the remaining zonular apparatus will help to stabilize the whole capsular bag. You see how easily the CTR is sliding along the equator of the bag, and now the trailing eyelet will be released to place the device completely inside the capsular bag. CTR is now located in the ciliary sulcus outside of the eye, and then fixated to the sclera in the zigzag manner, which in order to bury the knot of the suture. 4 or 5 bites are usually adequate to achieve good stability and fixation. Again, the CTR is positioned inside the injector tube and fixated to the 90 polypropylene with a long curved needle. And while injecting the CTR at the beginning of the procedure, we can actually see how it goes through the transparent injector tube, visible now because of the iris defect. You should be aware of cortical material and strapped to the equator of the bag by the CTR. Dear colleagues, let me introduce you Maluk Ovigi. CTR is now retracted to stabilize it, and we will be using vortex suture, which is fixated to the eyelet of the device. In the process of injection, we see that the bag is still supported by 2 capsule hooks, and we are gently inserting CTR inside the capsular bag. Vortex suture will be passed through 2 25 gauge vitrectomy ports, introduced 2.5 millimeters from the limbus. 25 gauge forceps are used to press the tip of the suture.
Sorry, sir, to interrupt, but we need to wind it up now.
Timing up.
Maybe 30 seconds it will do. 30 seconds.
Thank you, Devashish, for allowing me to attend in your course. Thank you. Lovely
Thank you,
It was
course.
my
Devashish.
pleasure to have you, sir.
Thank you, Devashish.
Kumar. We'll meet you soon in December in IRSI. Dr. Amar Agarwal told us that he'll planning to do the IRSI in December. Do you know about that?
Voice is breaking.
Thank you, everyone, for being a part of 79th AIOC.
Thank you. Thank you, everybody.
And with this, we conclude this hall now. We'll be meeting tomorrow. Thank you. This is your hall coordinator, Shivani Singh.
Thank you very much for your attention.
Thank you, everybody. Have a nice evening.
Thank you, Dr. Debashish.
Thank you, Minadi. Thank you so much. My gratitude to you and to sir also.
Thank you, Devashish.
Ananda, thank you. Ananda, thank you very much.
Thank you.